Everybody, welcome to Vijaya Diagnostic Center live webinar series. Today we are going to discuss about the clinical utility of CBC histograms. Even the topic appears to be very simple, but it's very important in day-to-day practice. As CBC is the one common investigation which every physician will advise. And starting with what is histograms, it's a graphical representation of blood cell population. The elaborated details of this topic will be given by Dr. Saleha Begum. She is having an experience of 4 years in the Department of Hematology, completely in a corporate setup. Previously, she is associated with Asian Institute of Nephrology and Urology. From last 1 year, she has been associated with Vijaya Diagnostic Center, Naga. I request Dr. Saleha to take over and elaborate the things on today's topic. Dr. Saleha, please.
Thank you, madam. Thank you for the introduction. Let us begin with the webinar today. The topic for today is clinical utility of CBC analyzer histograms. So, CBP or CBC, the complete blood picture or a complete blood count, is the most requested initial disease investigation. Um, Yeah. So it is a most requested initial disease investigation, which not only forms the basis of clinical decision making, but also provide clues to further investigations, diagnosis, and treatment. Nowadays, a very detailed CBP report is being generated like this by various modern automated hematology analyzers, which provides us with not only with the numerical data but also the graphical representation of that data in the form of histograms and scatter plot. A good interpretation of these histograms is very important to come to a conclusive picture of what exactly is happening inside the patient blood. So, like through this webinar today, let us explore the importance of this side of the CBP report, which is often neglected in interpreting patient results. Side by side, understanding how they are generated, interpreted, and what are the variations from the normal. So, but before going to the exact topic today, let us see the summary of an automated hematology analyzer. We get a result as fast as within 40 seconds. We can get a CBP result, and the working speed of these analyzers is around 60 to 80 samples per hour. But whatever may be the brand of the analyzer or a part or model of the analyzer, the working principle remains the same for all. That is the total count. For total count, it is Coulter principle, and for differential count, it is VCS technology, and for hemoglobin measurement, it is photometric methods. So. What happens inside the automated analyzer is once the whole blood is aspirated, it is divided into two chambers, the WBC hemoglobin chamber and a RBC platelet chamber. So in a WBC hemoglobin chamber, the VCS technology operates to give us the differential count as well as the sizing and numbering of the cells. In RBC chamber, the Coulter principle operates to give us the total count. So let us see what exactly is Coulter principle. Whenever a particle passes through a electrode through an aperture in between two electrodes, it produces a measurable change in electrical impedance. This measurable change is utilized to give the size and number of cells. The frequency of this measurable change in electrical impedance gives us a number, and the amplitude of this measurable change gives us the size of the cell. That is called as a Coulter principle, which operates in all automated hematology analyzers to give us the cell count and cell number. Coming to VCS technology, where the volume of cell is determined by again using the Coulter principle. Conductivity technology gives us the information about the internal structure of the cell. by passing alternating current in radio frequency range. And scatter utilizes the principle of flow cytometry, where cells are passed in a single line that intersects the that intersects the laser beam, and light gets scattered, and the scattered light gives us information about the cell surface and granularity. So that's how the different WBC population is separated into small cell, mid cell, and large cell population. We will see in the upcoming slides. So coming to histogram basics, histogram is nothing but a graphical representation of this numerical data generated by various automated analyzers. A thorough review of this histogram gives us valuable information about gives us valuable information which is usually missed in the numerical data. So few points are worth mentioning about this histogram. Like exactly, it should start at the baseline, should follow a smooth ascent, a peak, and a smooth descent, and at the baseline any deviations from this normal pattern have specific causes, which we will see in the upcoming slides. So coming to RBC histograms, RBC histogram, this is a Gaussian curve, which is also nothing but a symmetrical bell-shaped curve, where the discriminators are set between 25 to 250 femtoliters. That is the detection range of a RBC size. So the lower discriminator is flexible, and it is set at a 25 to 75 femtoliters, and upper discriminator is set at 200 to 250 femtoliters, and RBC graph should fall within these two discriminators, where the peak of the RBC graph corresponds to the mean corpuscular volume. Okay, we having seen the normal RBC graph, let us see what could be the abnormalities in the graph. Here you can see the RBC graph. The curve is not starting at the baseline. Instead, it is somewhere in the uh, middle of the lower discriminator. So the causes such graphs gives a signal as RL flag in the CBP report, and causes of such RL flagging is platelet clumps, fragmented RBC, giant platelets, microcytic RBC, meaning that there are some particles which are present in significant numbers, which are lesser than the usual detection limit of a RBC graph. So those particles, when present in significant number, they interfere with a lower discriminator, and the machine is unable to decide where to keep the lower discriminator. Hence the graph starts abruptly. So the causes will be platelet clumping, fragmented RBC, giant platelets, or microplatelet. So this is one variation in RBC graph from the normal. Let us see the second variation. Here, the graph is not ending at the baseline. Instead, it is abruptly ending somewhere in the middle. This means that there is some population of cell which is having a size larger than an RBC, and the upper discriminator is unable to decide on the placement, and hence the graph ends abruptly. So the reason for such a graph will be RBC agglutination, where many RBCs are clumped together, and they become larger size particles, and that's how they are represented at the upper end of the graph. So, and in case of very high lymphocyte population such as CLL, usually lymphocyte does not interfere with the RBC graph, because they are present in statistically insignificant number. When this number becomes high, such as in leukemia, the count goes in lakhs. So that's when they interfere with RBC detection. So they are counted as particles in the RBC chamber, and that's how the graph ends at the upper discriminator, not touching the baseline, giving us the clue that there are some larger particles present in the blood than the usual RBCs. Coming to the third variation of the RBC histogram, here you can see multiple peaks. This multiple peak represents, just a minute. Here you can see two peaks representing two cell population inside the patient blood. But the interesting fact about this dimorphic picture is we can make out whether it is anemia in development or anemia in recovery. Like here you can see the double peak is appearing at the right side of the curve, meaning that there is a larger population which is present in significant numbers. This larger population, depending upon the cause, could be anything. It could be a reticulocyte, which reticulocyte polychromatophils, when they are present, they indicate that it's a response to treatment. So, but when there are macrocytes, ovulocytes are present, it indicates that megaloblastic anemia is in development. So that's how the location of the peak determines the population. Suppose if we are seeing a peak on this part, on the left side of the curve, it means that microcytic population is present inside the patient's blood, and it could be an iron deficiency anemia in development. So that's how dimorphic peak helps us in determining not only the cause of anemia, but also the response to treatment can also be made out. And here we are seeing a dimorphic, here we are seeing a dual peak. Sometimes multiple peaks will also be present in cases of blood transfusion. So here you can see a normal RBC curve. The curve is exactly starting at the baseline, following a smooth ascent, a peak, and a descent, and eventually ending at around 100. So the peak will fall somewhere around 80 to 90 femtoliters, which is the normal size of the RBC, and that is perfectly correlated with a normocytic normochromic blood picture on a peripheral smear. So this is one example of a normal RBC histogram in practice, and this is, here you can see the curve is shifted to the left. Sorry. So here the curve is shifted to the left, and you can see a slight change here. The graph is not starting at the at the baseline. Instead, it is starting little above the baseline, and it is shifted to the left side, meaning that there is a microcytic population present in patient blood, which is causing that shape. And here you can correlate with the peripheral smear also, showing a microcytic hypochromic blood picture. So the reason for such a shift to left will be any cause of iron, any cause of microcytic picture, such as iron deficiency anemia, beta thalassemia, or sideroblastic anemia. Anything can have a shift to left in the RBC graph. This is another variation from normal. Here you can see the graph itself is starting very far from the origin, and it is taking a very broad broad curve and ending somewhere around 200. So this is a clear cut picture of a shift to right of an RBC histogram, meaning that the population present is mostly a larger cell population, which we can see very well here in the peripheral smear as a macrocytic anemia. So any cause of macrocytic blood picture presents with such histograms. For example, megaloblastic anemia, where we can find out a hypersegmented neutrophil also. Non-megaloblastic causes of macrocytosis also present with the same histogram, such as alcoholism, liver disease, hypothyroidism, or any medication where the patient, where the drug is interfering with DNA synthesis, results in macrocytosis. So in any case, there will be a shift to right side of the curve, and the variation in size of population determines the determined by the base of the curve. Here in this case, it is a very broad base curve. Okay. So next, this is a dimorphic histogram where you can see two cell populations, and here you can note that the cell population is on the larger side of the curve. So this could be anemia in recovery, where in the peripheral smear you can see two populations: a perfectly normal population and a microcytic hypochromic population. So this normal population, these newly formed RBCs are usually larger in size, so they are placed on the right side of the graph. So that's how a dimorphic picture looks like in a RBC histogram. Coming to WBC histograms. WBC histogram. The lower discriminator of WBC histogram is set at 30 to 60 femtoliters. It is fluctuating, and the upper discriminator is 300 femtoliters. So the detection range for WBC is 30 to 60 to 300. Not like RBC, it was 225 femtoliter to 250 femtoliters. But here it is 30 to 60 to 300 femtoliters. And there will be two troughs in the WBC histogram like this. The detection limit is 30 to 60 to 300 femtoliters, and there are two valley discriminators called as T1 and T2. They are somewhere around 90 to 60 femtoliters, and after 60 femtoliters, 160 femtoliter one is placed. So that's how the WBC population is differentiated into three parts, as small cell population, mid cell population, and large cell population, depending upon the size of cell. So the peak that falls between a lower discriminator and T1 is the small cell population, which is usually a lymphocyte. The peak between T1 and T2 is a mid cell population, which is nothing but monocyte, basophil, eosinophil. And the peak between T2 and upper discriminator is the large cell population, which is a neutrophil. So, but yeah. But as we know, the largest size cell in the peripheral blood is the monocyte. But when it comes to occupying a place in a histogram, monocyte occupies the third position in terms of size. This happens because in the WBC counting chamber, the lysing reagent lies the cell membrane, and the size of the cell corresponds to the size of the nucleus, not considering the cytoplasmic details. So that's how the monocyte occupies the third position in the graph, and the neutrophil becomes the first largest cell in the histogram. So that we have to keep in mind while interpreting the right side of the curve and the left side of the curve. So this is having understood the normal distribution of cells in a WBC histogram. Let us see the variations from the normal. This is the this here you can make out an extra peak at the just before the lower discriminator, meaning that there is some population inside the patient blood which is lesser than a small lymphocyte. So what could be that? Usually in cases of platelet aggregation, we see such abnormal extra peak in front of the lower discriminator. So here, this is a second variation of the normal WBC graph. Here you can again see the graph is not starting at the baseline. Instead, it is starting somewhere in the middle, indicating that the lower discriminator is unable to discriminate between a small lymphocyte population and a population that is even smaller than a lymphocyte, which is present in significant numbers. So what could be the causes of such WL flag is either platelet clumps, nucleated RBC, or cold agglutinins, or high background noise such as impedance noise in the automated analyzers. So any of these reasons could present as a WL flag, meaning the graph is not starting at the baseline. This is a third variation where the graph is not ending at the baseline. Usually, graph not ending at the baseline means there is some population which is larger than the neutrophils. But there is, as we know, there is no population larger than neutrophils. So there is the causes for such abrupt ending is extreme leukocytosis or WBC aggregation, as in satellitism phenomena. Sometimes what happens, the patient neutrophils gets in clumps in distribution, so that is called as satellitism phenomena, and that results in abrupt ending of the graph at upper discriminator, indicating that some larger population is there, but eventually that larger population will be a false representation. Instead, the causes will be a WBC aggregation or extreme leukocytosis. Coming to this variation here, there is an abnormal curve at the T1 level. The T1 flag is there. The T1 discriminator is not found here. It is unable to differentiate the first valley from the small lymphocyte population. So the causes for such a graph could be chronic myeloid leukemia, where you can see the extreme shift to left of the population, and the automated analyzer is not able to decide between the mid cell population and the lymphocyte population, since there will be eosinophilia, there will be basophilia, there will be mature granulocytes in the patient's blood. Coming to this version of the histogram, here you can see three flag, F1, F2 and F3 flagging. F1 flagging, the small and mid cell data may be inaccurate. The machine is able to place the discriminator, but it still gives us a flag for review. To give us an indication that this data is calculated but may be inaccurate depending upon the morphology, as in cases of acute lymphoblastic leukemia. We get F1 flag. F2 flag in mid cell data is inaccurate, meaning eosinophilia could be there. There could be monocytosis. There could be acute myeloid leukemia possible. In an F3 flag, the large cell data is inaccurate, such as in cases of neutrophilia, shift to left, chronic myeloid leukemia. We get F3 flagging, meaning the machine is able to count, but you cannot say accurately which population is exactly it is. So coming to scatter plots, there are various technologies available which generate scatter plots. Usually it is a VCS technology, a peroxidase staining or fluorescence flow cytometry. This is a scattergram showing the normal positions of different WBCs. The lowermost population is the lymphocyte. Here you can see in the corresponding picture, the blue population is representing a lymphocyte. Just above the lymphocyte is a basophil. Here you can see the white dots corresponds to basophil. And extreme right side of the scatter is the eosinophil. Orange population here you can see as a eosinophils, and neutrophils occupy a middle and upper position, like how you are seeing the purple color population here, and monocytes occupy the extreme left of the scatter but above the lymphocyte population. So here you can see the green color population is represented as monocytes in the scattergram. This is a normal WBC histogram and scatter plot. Let us interpret this. This graph is showing two curves and a slight middle bulge. This extreme left curve is giving us information about the small cell, which we have seen. It is nothing but lymphocyte, and the mid cell data between 100 to 200, and then the neutrophils. That is exactly getting correlated with the scatter plot. The lymphocyte population is giving us the left peak. The purple population, that is nothing but neutrophil, giving us the broad right peak. And the middle cells, green cell monocyte, basophils and eosinophil occupying the middle position in the graph, which is not much present in the graph, corresponding to the normal distribution. And you can see a normal peripheral smear of this case here. This is a case of eosinophilia. Like how I said, there is no middle cell population. Instead, the middle cell population is getting merged into the right side of the curve. So this could be anything. Middle cell population could be like monocytes, eosinophils, or basophils. But how we are able to differentiate this is from the scattergram or from the peripheral smear. In the peripheral smear, you can see there is eosinophilia. So this broad width of the curve is corresponding to the eosinophilic population. The mid cell population which is getting increased is eosinophil here in this case. Here in the scatter plot, you can see the dense orange population, which is nothing but again a eosinophils. So looking at this broad curve, which is getting merged into the neutrophil curve, one can think of eosinophilia or monocytosis or shift to left. But the discrimination cannot be made on the histogram unless you see a scattergram or a peripheral smear. So, coming to the next slide, chronic lymphocytic leukemia. Here you can see the WBC graph is showing only a single curve, not having the middle one and not having the right curve, which usually corresponds to the neutrophils. So, indicating that there is only one population present in patient blood, which is of small lymphocyte size, and there is a small bump at the end of the lymphocyte curve, which may correspond to the prolymphocytes. So here in this slide, you can see a graph which is having only a left curve that is corresponding to small lymphocytes on the peripheral smear and a increased blue cell population in a scatter plot. So if we see the histogram in conjunction with the scattergram and peripheral smear, a more clear picture we can get. This is another graph showing only one curve, not starting at the baseline and having a broad descent and not showing a large cell population. So upon examining the smear of such case, we have found out that there are NRBCs present in the patient blood, there are blasts present in the patient blood. So this the graph not starting at the baseline indicate that there is some population which is smaller than a lymphocyte. So here in this case it is an NRBC which is not letting the graph to start at the baseline. Okay, so NRBCs are there, the graph is not starting at the baseline, and the graph is showing a small bulge at the end of the lymphocyte population, that is nothing but corresponding to the blast window. So you can see in the peripheral smear also we are seeing blast, and in the scattergram again the blue cell population is more dense compared to other populations, and there are below the blue cell population there are red dots which are corresponding to a nucleated RBC. Okay. So this is another example where you are seeing a broad right curve and no lymphocyte curve, and there are small bumps in the mid cell population. So this shift to left in patient blood, not in the graph. The graph is shifted to right here. So in the peripheral smear, you can correlate the immature granulocyte, the myelocyte, the metamyelocytes, and band form. And in the scattergram, the dense purple population is representing a shift to left. That means immature granulocytes are present. This could be a case of anything: leukemoid reaction, chronic myeloid leukemia, anything. So basically, whenever the patient is having leukocytosis with shift to left, we get to see these patterns. Coming to platelet histograms, Platelet histograms, the discriminators, there are two discriminators. The lower discriminator is set at 2 to 6 femtoliters, and upper discriminator is set at 12 to 30 femtoliters, and there is a fixed discriminator at 12 femtoliter. So we have to again watch out for the same things in this graph also: baseline, starting point, ending point, and any irregularities in the peak. So same, three discriminators, and here you can see this abnormal platelet count not starting at the baseline. It means that the lower discriminator here is set at 2 to 6 femtoliters, right? So there is something lesser than 2 to 6 femtoliter which is creating this abnormality in the graph. But as we know, in the patient blood there is nothing of less than a platelet size. There is nothing less than a platelet size. Platelet itself is very small. So this could be any artifact such as noise, cell fragments, or high blank volume in the machine. So whenever we see such abnormality in the platelet histogram, we think of these things which are mostly technical, nothing to do with patient sample except for the fragmented cells. Okay. Coming to this type of abnormality, the graph is not ending at the baseline. Again, the causes are, as I said, the upper discriminator. As I said, the upper discriminator is not able to judge whether they are platelets or whether they are something larger than the platelets. So it gives an abrupt ending to the graph. The causes for such graph is platelet clumps, giant platelets, microerythrocytes, clotted sample, or fragmented RBC. All of them fragmented RBCs, again, they are having they will be much smaller than the routine normal RBCs. That's how they got counted in the platelet chamber. And clotted blood and giant platelets, maybe reaching to the size of an RBC. Again, they get a place in between a RBC graph and a platelet graph. So that's how you are getting this abnormality in the graph. Here you can see multiple peaks. The graph is showing two peaks, like how we have seen in the RBC histogram, that represented a dimorphic population. But in case of platelet histogram, it represents only platelet anisocytosis. Suppose there is destruction happening inside the patient's blood, platelet destruction happening, and simultaneous production of platelets, or maybe in cases of any dengue fever infection, there is STP transfusion. So that also creates such type of peaks. We have to keep in mind. And apart from that, platelet aggregation also causes such type of graphs. This is a graph, platelet curve starting at the baseline, but as you follow it, it is not ending at the baseline. Means that just now I discussed the upper discriminator causes. One such cause is a platelet clump. You can see here in the peripheral blood. Peripheral smear. These platelet clumps are counted as single large particles by the automated analyzer, and hence the graph ends in the middle, not touching the baseline. But another clue to the platelet clumps you can see in the WBC chamber, where the lymphocyte peak is not starting at the baseline. Instead, it is starting somewhere in the middle, as you can see here. But one such cause I discussed earlier for such peak is an NRBC. Now here in this case, it is a platelet clump. So which is very much logical here also. So we have to keep in mind, we have to interpret these graphs in relation to other cell population also, not only single cell, like in this case. Here you can see again a platelet graph starting at the baseline, okay, having a smooth curve but not coming to the baseline. So that another cause for such graph will be platelet satellitism. Here you can see in this smear, all the platelets are forming a clump around a neutrophil. So this is a case of EDTA induced platelet clumping. where you can see the graph is not ending at the baseline. And like the previous one, this WBC graph also is not starting at the baseline, instead somewhere in the middle, giving us another clue that there is something present in the blood which is lesser than a small lymphocyte population. So we have to look for platelet aggregation or NRBCs. So here in this case it is platelet aggregation. This is another platelet histogram, very irregular, but to start with it is starting at the baseline, very irregular curve, and maybe a dip in the peak, and again not at all coming to the baseline, instead very much ending higher up. So upon seeing the smear, we can make out giant platelets to large platelets in this patient blood. So whenever you are seeing such a platelet graph, you have to think of larger size platelets. So that's all. A good interpretation. I have come to the conclusion of this webinar. So, a good interpretation of histograms provides a wealth of information on many hematological conditions than mere cell count, which helps us to narrow down the differential diagnosis at a very early stage, even before other higher investigations are ordered. So that's all. In these lines we have to think of whenever we are seeing a patient. I mean, whenever we are seeing the patient CBC result, we have to look at graphs also and the scatters also, which gives us valuable information not only about the causes of the not only about the counts and numbers, but also the gives us the hints about the causes of such counts or numbers. So that's all about today's webinar. Thank you.
Thank you, Dr. Saleha. It was a very well presentation, starting with the principles used by automation cell counters, explaining the basis of histogram and interpretation of histogram, and adding more to the flags in the histogram interpretation. I just want to add one thing that, as you said, platelet histoflags, there was a high plant value and cell fragments. That may be a technical issue that can be resolved by giving a auto rinse in automation cell counters. That may be the remnants of the previous sample. That may give the histogram lower value, not touching the baseline in platelet histograms. I Can you explain what is this EDTA-induced thrombocytopenia and how it can be prevented in pediatric age group, especially in the dengue season, as we encounter most of the cases like this?
Um, yes, ma'am.
Dr. Saleha, is it audible?
Yeah, ma'am. You are audible to me. Am I
Can you,
audible to you? Yeah.
yes, can you elaborate this EDTA-induced thrombocytopenia and how
Yes,
we
ma'am.
can
Yes,
reduce
ma'am.
that in pediatric age group? Can you please give
Uh,
a line of information on this?
yeah. Yes, ma'am. Actually, what happens inside the patient blood is this EDTA, it causes conformational changes in the epitope, which becomes the target for the IgG or IgM type of antibodies. Okay, so this IgG or IgM type of antibodies, after getting I mean they after getting exposed to the epitope, which is caused by EDTA, it induces agglutination of platelets. That's how platelets are agglutinated, and they give us a flag of platelet clumps in the graphs. How you can counter this problem is, in pediatric population you can go for a direct smear or capillary blood you can take to avoid such EDTA induced thrombocytopenia.
Thank you, Dr. Saleha. Once again, it was a nice presentation by you on this regular topic of clinical utility of CBC histograms. I hope it will be helpful for day-to-day practice for all the physicians and post-graduation students for their academic purpose. Thank you, one and all.
Thank you, ma'am.